our rehabilitation of the injured runner, both live and online. If you missed us this year, we have a really busy fall coming up. So make sure you don't miss us if you want to get us in this year. Let's see. Next weekend, I'm in Connecticut, September 10th and 11th. In early October, Jason's in Minnesota, October 8th and 9th. If you missed us in Minnesota, I'll be in Annapolis, Maryland the week after that, so October 15th and 16th. And then at the very end of the year, to wrap the year up, we are in Golden, Colorado. Let's see, November 12th and 13th. And then if you can't make it to a live course, we've got another online course beginning September 27th. So just at the end of this month, make sure you don't miss us. We've had a really great year of courses so far and looking forward to this fall as well. All right. So today I'm going to talk about I'm actually going to piggyback off of Lindsay Huey's topics for the last couple of weeks. On Clinical Tuesdays for the last couple of weeks, Lindsay's been talking about saying less better and how to cue our patients. This is really relevant to treating injured runners as well, specifically when we're doing any gait mechanics evaluation and then doing gait analysis or gait retraining as well with gait retraining drills. Saying less better is not only relevant, but it's really, really important for our patients to be successful at any kind of gait retraining drills that we're doing. Really, the whole point is how to say less words so that we can be more effective, so that they can get better faster. So got a couple of tips here that we're going to go through in order to in how to execute saying less better when we're doing gait evaluation and running gait retraining drills. So number one, decrease the number of mechanical faults that you're going to highlight with that patient. Once you have been through your running gait analysis, choose one primary mechanical fault for that individual that most correlates with their symptoms. Don't pick out everything. It's overwhelming for a patient. They don't want to know every single thing that is wrong with their gait mechanics. They just want to know how to fix their symptoms so that they can continue running. So choose one that you think is most related to their symptoms. That takes a little bit of practice. It takes a little bit of experience, but for the patient, much better off if you just choose one. Number two, decrease the number of gait interventions that you're going to use, specifically with the gait retraining drills. Excuse me. We do this because if we add on more than one gait retraining drill, it becomes really, really confusing for that individual. And it's really difficult to do. If you don't believe me, go ahead and try it. Increase your cadence by 10% and try to do mirror training at the same time. It's next to impossible to be successful at two different new gait retraining drills at the same time. So just choose one. Number three, decrease the number of words that you're going to use when you explain what you're doing for that gait retraining drill. Say less better. And we'll go through this in just a few minutes. So I'm going to give you a scenario here. Super common scenario. You've got an injured runner. Let's say they have medial tibial stress syndrome. Could be patellofemoral pain, could be IT band syndrome. But for this example, let's say it's medial tibial stress syndrome or shin splints. They're training for a half marathon. They come in, they have symptoms. You get them on the treadmill, you do your running gait analysis, and they've got a cadence of 160 steps per minute. The mechanical faults that you see are an overstride with a lack of knee flexion at initial contact, an upright trunk posture, as well as a medial knee collapse with overpronation. Now, all of these mechanical faults are very, very common in injured runners. We often see them all together. We often see them individually. But now we have to choose one mechanical fault out of those three big ones either the overstride with lack of knee flexion, the upright trunk posture, or the medial knee collapse with overpronation. We have to choose one in order to move on to gait retraining. So I'm going to choose Cadence Retraining. They have a low cadence, 160 steps per minute. And I know that from prospective studies, a low cadence, 160 steps, or actually 164 steps or less, has been associated with development of medial tibial stress syndrome. So that's the one that I'm going to choose. Could you choose the upright trunk posture and move on to gait retraining from there? Absolutely. It's just up to your clinical reasoning to choose which mechanical fault is the most important to address. I'm going to choose cadence retraining not only because it's been prospectively associated with medial tibial stress syndrome, but also by increasing the cadence, I think I can also reduce stride length and potentially increase the knee flexion at initial contact as well. So, okay, I've chosen my one. I'm going to now choose one intervention to address the primary mechanical fault that I chose. So my intervention is going to be cadence retraining. I do want to consider the goal of that individual running in front of me, and their primary goal is to reduce symptoms. And I know that I can do that if I can manipulate their mechanics enough to change the stress or the load on those injured tissues. I think that cadence retraining or step rate manipulation is going to be most effective at doing this the fastest. I could do a forward lean drill, but it may not be as effective as quickly as cadence manipulation. I could also look at their feet, and maybe they need orthotics for overpronation. That is a clinical judgment that you have to make. For this scenario, I'm going to choose cadence or step rate manipulation. So number 3 is saying less better. So reducing the number of words that you're going to use to try to get them to increase their cadence. In this case, what I don't want to do is to tell that runner, okay, I'm going to have you get back on the treadmill. We're going to start running. I'm going to increase your cadence to 176 beats per minute from 160. What I want you to do when you're running is to try to match the beat of the metronome, but I also want you to try to reduce your stride length or land a little bit closer to your center of mass. And I also want you to land with a little bit more knee flexion at initial contact. That's not going to work. It makes no sense to that runner. All they heard was, I'm going to have you get back on the treadmill. That's it. They don't know what to do from there. They don't know how to decrease their stride length. They don't know how to increase their knee flexion at initial contact. We have to choose less words. So in this case, what I want you to say, if it was my patients running in front of me and I was choosing cadence manipulation, what I would say is once they're on the treadmill and once they're running again, so now they're on the treadmill and they're running, I'm going to say, listen to this metronome and match your foot strike to each beat of the metronome. And that's it. And then once they're successful with that, then I can go back and explain why we did that drill. I want them to be successful first. I want them to feel a difference in their symptoms first, hopefully right away, if we've chosen the right gait retraining drill. And then I want that buy-in from the symptom reduction for them to know why I chose a certain gait retraining drill. So in this case, we can get them off the treadmill and I can say, I had you running at 176 beats per minute. How did that feel? If they want more information and they want to know why I chose 176 beats per minute, I could then go into the literature as to why a 10% increase in habitual cadence has been shown to positively influence running gait mechanics. If they want that information, I can then go on to say, now that we've done this trial run of cadence training, I want you to go home and I'm going to give them a program of 2 minutes on and 3 minutes off, and 2 minutes on and 3 minutes off for their gait retraining. Very, very common gait retraining prescription that we would do. If they want more explanation as to why, I can certainly give it to them then. It might have lost YouTube. But for now, I want them to be successful first. So I'm going to say less and try to do that better first. Lindsay, in her podcast, talked about external versus internal cueing. This is really important as well for runners. I typically will go towards external cueing in preference to the internal cueing. The reason for this being, especially for gait retraining in runners, is that when we use internal cueing, it's typically because we are trying to influence a very localized region. And so we're trying to change a motor pattern in one single joint. Often, when running, that's not the main goal. Often with running, it's happening much too quickly that it's nearly impossible for someone to focus on a single joint. And especially in more novice runners or individuals who may not have quite as much body awareness, it's really difficult for them to focus on a single joint with something as quickly done as running and as repetitive as running as well. Some of the gait retraining techniques we use, like forward trunk lean, is more of an internal cue. It's just my preference to go more towards external cues as soon as I can because I've found them to be a little bit more effective with injured runners. So now that we've gone through our initial gait retraining process with saying less better and doing less better, we have to go on to part two, or there's a big question here on part two. And the reason I bring this up is because we get this a lot in our both our online and our live courses on how and when do we cue secondary mechanical faults with running, or do we even cue them? So, for the scenario example, if that individual has spent a couple of weeks now on cadence retraining and they've been successful at that, and they come back and they still demonstrate an upright trunk posture, and they still demonstrate medial knee collapse, and they still demonstrate overpronation, but they've improved their cadence, do we address those secondary mechanical faults? So, my first question in this scenario is, are those secondary mechanical faults contributing to their symptoms? Do they have current symptoms? If symptoms have resolved as a result of your interventions, then my question would be, why are we going to intervene more and change their running mechanics even more when their symptoms have resolved? We do have to consider if some of those secondary faults may have been contributing factors to the development of those injuries. And in that case, I may address some of those faults. But I do want to keep in mind that we're not trying to create perfect runners. We don't know what a perfect runner is. We have no idea what those gait mechanics look like. And so once the symptoms have resolved, I'm very reluctant to then go on and continuing to address certain mechanical faults unless I think that there's a good reason that they may have been related to the initial development of symptoms. So very rarely will I continue on and go and address secondary faults if symptoms have resolved. I prefer much more to spend my time cueing that runner on how to lift appropriately. So I'm talking about like the lifts we can heavily load, the deadlifts, the squats, even more upper body lifts, because I want them to be able to load those lifts heavy so that they can build resiliency in those tissues and tolerate loading in the future. And I think that I'm going to be much more effective at doing that by sending that individual home with a heavy load lifting program than I am with more gait drills. That's only my preference. That's only from my own clinical experience. But that's where I'm going to spend my time because I know that in order for that individual to be able to lift heavy, they have to have good technique with some of those lifts. And so that's where I'm going to spend my time. Okay, to summarize, so this idea of doing less better or saying less better works really, really well with injured runners. It works well for gait analysis. It works well for gait interventions or gait retraining. We just have to keep a couple of things in mind. So one, reduce the number of mechanical faults that you're going to focus on. Pick a primary mechanical fault that you think is associated with their symptoms. Number two, reduce the number of interventions. Choose one gait retraining drill that you think is going to most affect that primary fault that you chose. And number three, reduce the number of words that you're going to use to cue. As minimal words as you can possibly use is going to likely result in more effective gait retraining for that individual. They're going to get it just a little bit better, a little bit more quickly. And they're going to be a little bit more successful with that as well if you can use less words and say less better. All right, that's it for me. That's all I have for you today. I think we may have lost YouTube. That's okay. I think we're still on Instagram. So have a wonderful holiday weekend, and thanks for hanging out for Fitness Athlete Friday. See y'all.